Good evening again. Thank you so much, everyone, for joining. Again, my name is Cheryl Johnson. I'm the Executive Director with Weinstein Hospice and Palliative Care. I'd like to thank everyone for joining us this evening for what I know will be an informative discussion with lots of great questions and answers. I just want to take a minute before we get started to tell you a little bit more about Weinstein Hospice. As Georgia's only Jewish hospice, we have been serving the greater Atlanta community, both Jewish and non-Jewish alike, since 1999. Our Danny Sklar Palliative Care Program also provides supportive services for people still in treatment for heart or pulmonary disease and cancer diagnosis. And we certainly appreciate Danny Sklar and his family's ongoing support. Weinstein Hospice is an entity of Jewish Home Life, which is a nonprofit network of at-home care services and residential communities that support every stage of aging. Tonight, we are going to share with you our expertise on the latter stages of that journey so that you can be more informed about care options when you or your loved one are facing life-limiting illness. I'd like to introduce to you our moderator for this evening, Janet Ziffer, who is a member of the Weinstein Hospice Board of Advisors. And she will introduce our panelists for the evening. Janet?
Thank you, Cheryl. I would like to welcome everyone tonight. A couple housekeeping items before we get started. First, if you can make sure that you are on mute and remain on mute during the course of the webinar. That way we can make sure that everyone hears our speakers. And we will have plenty of time for Q&A at the end. So feel free to put your questions in the chat or the Q&A box, and we will cover those later in our session. So I would like to introduce to you our speakers tonight. We have Dr. Sharon Neulinger, who is a board certified internal medicine and hospice and palliative medicine provider with the Southeast Permanente Medical Group. That's a mouthful to say. And she's on staff with Emory St. Joseph's Hospital and Emory University Hospital in Midtown. Dr. Neulinger received her medical degree from SUNY Downstate and did her postgraduate training at Emory University and has been in practice for over 30 years. And Sharon is also a member of our Weinstein Hospice Board of Advisors. Carla Polikov is a staff member of Weinstein Hospice and joined in March of 2017. She has 16 years of hospice and medical social work experience and received her master's degree in social work from Tulane University, coming originally from Mississippi. So thank you to both Carla and Sharon for joining us tonight. I think this is going to be a really informative session for all of us. We are going to start by helping everyone understand the continuum of care, and then moving on to understand background on what palliative and hospice care are. We're going to talk a little bit about both of them and then do some compare and contrast about the two types of care so that you can get a better understanding of where there are similarities and where there are differences. And then we have two case studies of patients that we will share with you as well. And Carla and Sharon will share some perspective on those situations. And then we'll take your questions. So again, don't forget to put them in the chat. So I'm going to turn it over to Sharon first to talk about the continuum of care.
Thank you, and thanks everyone for coming. And Janet, do you have your little pointer for this?
Oh, yes.
So thanks everyone for coming. I just wanted to say that hospice and palliative care, modern hospice really started back in the mid-20th century in England. Cicely Saunders was a woman who got that moving. This country was a little bit later, influenced by Elizabeth Kubler-Ross, who wrote the book called On Death and Dying that became very well read. Hospice became a Medicare benefit in the 1980s, and that's when things started to bloom. palliative care has theoretically been around since the 60s and 70s, but it's really been growing in the 21st century. It was recognized by the World Health Organization as being a specialty in 2000, and board certification in this country became available in 2006. More and more hospitals are having programs. I mean, every year the number of hospitals that have inpatient consultative palliative care programs goes up. So this graph is kind of helpful. It helps us look at palliative care as kind of an umbrella. It encompasses hospice, which is sort of at the end, the yellow box, but palliative care can start much earlier in a time of a diagnosis of a serious illness. And as time goes on, most of the care could be curative care, which is the white on the top. But as the illness progresses and as the patient becomes sicker, more needy, palliative care can take over and curative care becomes less, until when there's a 6-month prognosis, and Carla will speak about that, the patient can be eligible for hospice care. So both palliative care and hospice care involve specialized medical care for people living with serious illness, focus on providing relief from the symptoms and stress of the illness, and aim to improve quality of life for both the patient and the family. Do next slide. And palliative care sees the person beyond the disease. It's provided by a team, especially trained team of doctors, nurses, obviously social workers, chaplains, clinical pharmacists, who all work together to provide an extra layer of support. It's based on the needs of the patient and not the patient's prognosis. And it is appropriate at any age and any stage in a serious illness. It can be provided along with curative treatment, as we saw in the previous graphic. What can you expect from palliative care? Relief from symptoms, pain, shortness of breath, fatigue, constipation, nausea, loss of appetite, insomnia. Palliative care can help you carry on with your daily life. It can improve your ability to go through medical treatments, meaning help you with side effects, helps you understand your condition and your choices for medical care, and give you the best quality of life. There are inpatient home palliative care programs that will bring medical care to the home and minimize unnecessary trips to the doctor's office when it becomes too difficult. And throughout this time, palliative care teams can provide support to families as the disease progresses and advise when it's time for more support, which would be provided by a hospice. And it can be looked at as a bridge between curative aggressive treatment and treatment that focuses on comfort and symptom management. And the bridge can be short or long. Sometimes people wait too late to take advantage of these services, and they can be in palliative care for a very short time and transition over to hospice. And I've taken care of outpatients in a palliative care clinic for 4 and 5 and 6 years. So it doesn't mean that hospice is immediate or even necessarily inevitable. And as a palliative care physician, I feel that I kind of like the quarterback sometimes for the team, because when patients get sick and things get complicated, they could see lots of doctors, lots of specialists who tell them different things, about their one organ system. And the palliative care physician can help put things together and kind of prioritize things. And a saying I heard once that really sort of brings it together to me is like, in modern medicine, there is a lot we can do to the patient, but what are we doing for the patient? And with palliative care, we could step back and say, what can we do for you? What are your goals? How can we help you reach your goals? Next.
Thank you, Sharon. We're going to ask Carla now to speak a little bit about hospice care.
So lots of people hear the word hospice or told that their loved one may be appropriate for hospice, and it sends a shiver down their spine or dread. because people often equate hospice with death. However, I'm a big believer that hospice equates to life and quality of life. When someone mentions hospice, it's really talking about the philosophy of care, where the goals for someone's life, if it is determined to be at the end stage, the goals really become focusing on comfort, symptom management, quality of life, and dignity and respect. Hospice is not about doing anything at all to hasten end of life or make death come sooner. At the same time, it is making a conscious decision to not pursue aggressive treatment to prolong life unnaturally. It's really about allowing the body to do what it wants to do and respecting it, with the goals of saying whether someone has days, weeks, months, or years, we don't know. But the goals are really to live the best life possible for as long as that person is supposed to live. Hospice is very much an interdisciplinary approach where we're focused on physical comfort. And I think lots of people think of hospice and think of pain management. And that is a big part of it. Physical comfort, things like pain, anxiety, agitation, respiratory issues, nausea, any kind of restlessness and distress. But just as important as the physical piece of comfort, the emotional and spiritual piece of it is looked at as just as important under the hospice philosophy. Sometimes we work with patients that absolutely have no symptoms or are very much at peace being at the end of their life and have nothing they feel like they need to accomplish. But oftentimes it's the families that are sitting on the edge of their seats worried about what's next? What's next? What does this mean? So hospice is really there to walk families through what's happening, what we anticipate happening for the future, and to really communicate with everyone so that people can spend quality time with their loved ones versus being stressed, anxious caregivers all the time. Lots of people, again, hear the word hospice, and it's a very scary thing for them. One of the main things we hear is, I don't want to give up, or I'm giving up hope if I choose hospice. Hospice is absolutely not about giving up hope. It is hoping and praying that someone feels better. And if that happens, hallelujah, that's a wonderful thing. Some people go on hospice and the doctors anticipate that their prognosis is poor. And we see that they actually thrive under hospice care and sometimes get discharged. At the same time, we're there to be very realistic and educate everyone around their loved ones about the diagnosis, the prognosis, and symptoms related to it. Some people are on hospice for very short periods of time, and some people are on it for months and months, and sometimes years or more. Again, we don't have a crystal ball. I wish we did. By someone going on hospice, all it means is that their doctor feels like if the disease were to continue its natural course without aggressive intervention, they would not be surprised if the prognosis is 6 months or less. But that's all based on science and medicine. Nobody truly knows what the future holds. So someone may live much longer than the initial prognosis. Hospice is not about coming in and changing everything. Some people have quite a few symptoms related to their diagnosis. If someone has a metastatic cancer or an end-stage organ failure, there may be pain and symptoms. And then there's some people that have absolutely no symptoms and just may be more tired as life approaches the end. We're not there to give people medicines that sedate them unnaturally. We're not there to push anything on anyone. We're there, though, to be proactive, to talk about anything and everything that could happen and put things in place and educate everyone around about it. That way, if it does occur, it's not this moment of, oh my gosh, what do we do? What do we do? Everyone can take a deep breath and say, you know what? My nurse and the team said this may happen, and this is how we're going to handle it and make sure that the people we love are comfortable and not suffering in any way. Most people can be managed in the home on hospice care. Lots of people think of hospice as a place you go. Yes, there are inpatient facilities, but rarely are they used these days unless someone is in acute crisis and for short-term management of pain and symptoms. Most people can be managed anywhere that they consider to be their home environment, whether that be a private residence, an assisted living, a nursing home, a personal care home, a family member's home. We come in anywhere that someone considers to be their home environment and offer skilled services to, again, make sure the resources are in place so that someone can be cared for comfortably and appropriately with dignity and respect each step of their life.
Thanks, Carla. If you have questions, again, don't forget, as we go through this, please put them in the chat and we will get to them at the end. Now what we want to do is look a little bit more closely at palliative and hospice care. And we put together for you a little bit of a comparison on the next couple of slides. So I'm going to ask Carla to start just kind of talking through these different aspects: patient goals, common diagnoses, where care is provided, and then Sharon will chime in as well.
Sure. So hospice care, generally, the majority of people that are coming on hospice have a prognosis, again, of likely 6 months or less, and philosophically feel comfortable with shifting the goals to comfort, symptom management, and quality of life. It does not mean they can never return to the hospital, but most people on hospice's goals are to remain at home surrounded by the people that they love and that love them. And they're not wanting to return to the hospital and go back and forth for diagnostics. Generally, under hospice care, people are not getting ongoing lab work or scans or transfusions that would be considered as life prolonging or diagnostics in any way. We're really just doing care that focuses on making them feel better each and every day. As far as things go with hospice care, there's a plethora of different diagnoses that make someone appropriate. Obviously, lots of people think of metastatic cancer or the end stage of an organ failure, things like lung disease, heart disease, end stage kidney failure, end stage renal disease, end stage Alzheimer's, Parkinson's, ALS, malnutrition, complications related to a stroke. But also a lot of the referrals we get and a lot of the people that are appropriate are members of families that are just of an older age that seem to not be thriving despite following all doctor's orders and taking medicines exactly as recommended. The body is just starting to slow down. And that's something that you could discuss with the physician if hospice may be an appropriate option. As mentioned, hospice is provided anywhere that someone considers to be their home environment. It is covered 100% under Medicare, Medicaid, and most insurance programs. And it's a very flexible benefit. So it's the one-time insurance doesn't say you have X number of visits this many times a week for this amount of time. To hospice care, the organization that you choose, be it Weinstein or another agency, we are tasked with being good stewards of the benefit and doing whatever's necessary to manage someone, whether they need one nursing visit a week or visits daily, whether they need one piece of equipment or a full home of equipment. It's really up to the discretion of the organization and doing whatever's necessary to manage someone based on having to partition care out to different providers.
And Sharon, from a palliative care perspective, what would you add to what Carla said that might point out a few nuances or differences?
Yeah. A lot of the diagnoses, I think, are very similar, except for maybe the diagnoses are very similar. And it's sort of the patient, if the patient's continuing to get curative or disease directive treatment or not. Palliative care patient goals, to have a good quality of life, understand their options, be able to clarify their wishes and tell their family members what they want, complete their advanced directives, manage their symptoms, and learn about available resources. And again, it can, most hospitals now have, big hospitals have palliative care teams in the hospital. There are home palliative care programs, and there's, and home can be, again, just like in hospice, a house or a assisted living or, family house, personal care home. And there are outpatient palliative care clinics. And unlike hospice, which is like a a defined benefit, palliative care can vary from place to place and from insurance company to insurance company and agency to agency. So it's much more variable.
I just flipped to the next slide because we do cover that at the bottom.
Right.
And when we were talking about the session, Sharon was pointing out to us how, hospice is very clearly defined, what it covers, what's included. Carla mentioned earlier that it's covered by Medicare or Medicaid, but that's not always the case with palliative care. Is that right, Sharon?
Right. It depends, very much. Different insurance companies might have their own palliative care programs. I know like Emory has a palliative care program. Wellstar has one, and they are different.
So we're kind of in early stages of palliative care development versus hospice care, it sounds like.
Right.
And on the second page also, so we've covered a bit of the who pays for this. Carla, just help us again kind of understand the differences or similarities between the two types of care in terms of who's providing it.
So with palliative care, as Sharon mentioned, there's a specific palliative care team that's often checking in with someone who receives that service, but it's not necessarily as much in-home care or guided care. Whereas with hospice care, you're going to have members of a team that are in the home or, again, wherever they live, generally multiple times a week. So there's going to be a consistent nurse who's visiting to assess what's going on and communicate changes. We offer certified nursing aides who can help with bathing, changing bed linens, personal care, because really hygiene is one of the few things we really can control when someone's body is changing. There's social workers to help with the emotional aspects as well as to connect with resources in the community. We have chaplaincy and spiritual care because that's a very important part to someone's comfort and feeling peace at end of life. There's volunteers. We have a physician available 24 hours a day, as well as a nurse practitioner. And really the goal is to simplify life. So instead of going to the oncologist about the cancer or the cardiologist for the heart or the neurologist for the brain, hospice is really looking at the whole body and how it's working together. And instead of, as I think Sharon mentioned earlier, them kind of being palliative care, the quarterbacks, I kind of use the same similarity for hospice. We're coming in to look at the big picture and kind of discuss the options for managing care with the goal of simplifying life so that families and patients aren't going to this person for this and this person for this. When someone goes on hospice with any organization, they're going to have 24/7 on-call support. And for anything related to that person's illness, someone's going to be able to direct that person on what to do and why to do it. And if needed, visit, even if it's in the middle of the night or on the weekend or on a holiday, because overall, the goal is to keep at home. And again, not to say that we're happy about end of life, not to say that we can make life easy in any way, because there's nothing easy about thinking about losing someone you love in any circumstance. The goal is to make it a little bit easier, to take that weight off the shoulder and say, you know what, we're going to have a group of people that are experts on this. Just like, again, the oncologist specializes in treating the cancer aggressively, the hospice staff specializes in treating the symptoms of the disease aggressively and educating everyone around to really try to make it the best possible scenario in such an awful time.
Great. Sharon, anything else you would like to add about the care team before we move into our case studies?
Well, the care team is similar, and I was sort of sneaking into the chat and saw some of the questions. And one of the things in working with a primary care specialist, when I was working today, and I had a conversation with one of the oncologists about a few of the patients we're seeing in common. So we say works with them, she's some of the patients having more pain, what should she do? And then I happened to tell her about somebody else I saw today, one of her patients who's doing great. So we really communicate, and now there's good communication with texting and, emailing and things. So we try to keep, I always try to keep either the primary care doctor or the main specialist. It's usually an oncologist. It's seems I talk to mostly oncologists, cardiologists, pulmonologists, and neurologists. I try to keep them in the loop of what, send them my notes and we communicate regularly.
Great. Well, we're going to move into showing you a couple case studies, as I said, that we've put together. So these, again, are just two examples of different scenarios. Our first is Mr. R. And as you can see reading through this, he's a 63-year-old man, has metastatic lung cancer. He has received a variety of treatments and has had surgery. He's still able to move around, take care of his personal care needs. His oncologist reports there's no further lines of treatment available, and that the cancer continues to progress despite the treatments that he's received so far. He does have a great deal of pain. He doesn't sleep well, and has been hospitalized for a variety of different reasons. His wife is still working, so he's at home much of the day by himself. But he does want a second opinion. He can't get into a specialty hospital, MD Anderson, for 3 to 4 months, but he wants to continue in that time with scans, labs, transfusions as part of his treatment, and potentially ongoingly. So taking into account this scenario, Carla and Sharon, what are your perspectives on which type of care might be best for Mr. R?
Sorry, go ahead, Sharon.
No, this is one, I think this is a perfect outpatient palliative care patient. I mean, he wants to get scans, labs, transfusions. And he wants a second opinion, and hospice. I guess you could talk later about he could start hospice and revoke and go back, but this would be the kind of person I think who could come to a palliative care clinic. It sounds like he's ambulatory. We can manage his pain and his insomnia, monitor him for symptoms, before they would require hospitalization, hopefully monitor him for infections, sort of try to keep him doing as well as he can for the 3 or 4 months till his MD Anderson appointment comes. I mean, he can get scans and transfusions during that time. And if he is doing well enough to go to MD Anderson, fine. And if he declines during these 3 or 4 months, and if he gets worse, which may be, palliative care would be there to help him and his wife and manage his symptoms. And sometimes the time may come where he realizes in 3 or 4 months he can't get on a plane to fly to MD Anderson. He's just too sick. It's not happening. And palliative care could help sort of ease him into hospice care.
And I would agree. Certainly from a medical perspective, Mr. R is very appropriate for hospice in that he has metastatic cancer and the doctor's not able to offer more treatment. However, like Sharon mentioned, because he's wanting to continue frequent labs, transfusions, and scans, I would recommend palliative care. If that last line was not on there about wanting to continue those things, if he did not want to, I would strongly encourage hospice, even if he still wanted to get to MD Anderson. Sometimes having that extra special care and attention is better than not having the extra special care and attention. So if his goal was to remain at home, not to go back to the hospital, and he was sick of getting labs and scans, but he did want to go to MD Anderson, I would consider encouraging him to go on hospice care and then reassessing in 3 to 4 months to see if he's strong enough to proceed to MD Anderson, and he could always sign off to hospice. But again, in this case, it sounds like palliative care would be the most appropriate option.
Great. And our second case study is Mr. M. And Mr. M is a 95-year-old who lives in a condominium. He has private caregivers and his family is frequently checking in and helping care for him. He does have some generalized dementia that comes with the natural aging process. He has high blood pressure, some cardiac history, recurring urinary tract infections, but no specific end-stage diagnosis. He sleeps much of the day. His appetite has decreased. He's lost a large amount of weight in a small amount of time. And while he used to be independent, he now needs assistance in his daily care regimen. And he also has had decreased socialization with neighbors and family. So Carla, what's your perspective on Mr. M?
So Mr. M is probably one of the most common referrals we get at Weinstein, and I assume other agencies do as well. There's not one specific diagnosis that someone would look at and say he's terminal. He doesn't have end stage of an organ failure. He doesn't have the end stage of dementia, but he's 95 years old. And again, despite having great care and despite following doctor's orders, his body is starting to slow down. He's had a 15-pound weight loss, which is pretty significant. Usually we're looking for about a 10% weight loss within the last 6 months. He is functionally changing and declining. And oftentimes doctors just feel like this may be the beginning of the end. The body is starting to slow down, and something tells them that in 6 months that this patient is either not going to be with us or be in a much decompensated state. In this situation with Mr. M, I would likely recommend hospice care for him because, again, if he's not wanting to go back and forth to the hospital at his age, if the family is supportive and philosophically aligned with allowing his body to do what it wants to do, I think that hospice could be beneficial to provide oversight and support and education that the body is starting to shut down.
Sharon, any thoughts from your perspective?
No, I agree. I mean, I learned from Carla that I didn't even know that this diagnosis would qualify someone for hospice, because again, he didn't have, like, you couldn't say end stage cardiac disease, just getting old. But I think, I mean, that, and I wrote it down for myself to remember this diagnosis of senile degeneration because I was unaware of it. But I agree, and it sounds like he could benefit from hospice. So it's good.
Thanks. I will just chime in and say that this very much is the type of situation that my family went through with both of our parents. And again, these are just two examples of situations that that a family might be coming up against, and your family's needs may be very different. So we're hoping that through this conversation tonight that you can get some ideas about, how to identify what type of care might be best, but then also what resources are available to help you determine what's the best care for your loved one. So Carla, would you mind just quickly reviewing when you call an organization about either hospice or palliative care, what are the types of things that you will be, that prospective patients will be asked about?
Sure. So whether it's Weinstein or any of the other agencies in the community, when you call to inquire about services, most of the agencies will want to know about the patient, their age. They'll want to get demographics to know where they live, what their diagnosis is, if you think you're seeking palliative or hospice care, or even if you're unsure of what you need, if you're just inquiring to say you want to know about one or the other to determine what's most appropriate. And then usually to actually get services and be admitted onto a program, it does require a doctor's order. I find that many doctors, while they may not bring up hospice or palliative care, are very open to having the conversation. Again, not palliative physicians per se, they're very open and about goals of care and having those discussions, but sometimes primary care physicians or specialists are scared to really have conversations to say, okay, where do you want to go from here? But if the family opens that door and says, do you think this may be appropriate? I'm considering, or I've heard about this. They may say, you know what, that's a really wonderful idea. So both programs do require a doctor's order, just saying, to initiate services for hospice or palliative care. They'll need insurance information and to know what the understanding of the prognosis is. Again, have y'all been told that this is terminal, or no, is this more chronic, or it's terminal, but you're still wanting to pursue aggressive measures, those kind of things.
Great. So we are now going to move into our Q&A section. I'm going to actually stop sharing my screen so you can see, so we can pull up our chat, and I'm going to scroll up to the top and see what kinds of questions we have. Let's see. So Harold asks, what kind of care is available for a nearly 106-year-old who lives in her home with a living caregiver but needs help to get out? Person is of sound mind, fiercely independent, but it's difficult to get out for services. How do they go about getting in-home care?
Well, so hospice and palliative care, specifically when someone generally has a chronic or terminal illness. And yes, at 106, we know that life is not infinite and someone may not live, but if they're doing well, which we certainly have seen people live into their hundreds these days, and you just need assistance getting out. Unfortunately, unless someone usually has financial constraints, that is looked at as more of not a medical need, but more of a social need. So people would often have to initiate care with more private caregivers, et cetera. If someone's trying to get to a doctor's office but cannot get there, Atlanta's fortunate to have some home-based physicians these days. There are concierge medicine doctors, et cetera. And with the advancement of electronics, people can also do telephonic visits if it's hard to get out. There's lots of transportation resources, et cetera. But generally, hospice and palliative are not looked at as programs just to get someone out of the house for socialization or doctor's appointments. It's that they have a condition that prohibits them from being able to do those things or would not benefit from it.
Thanks, Carla. And Sharon, a couple questions about palliative care. Can it be available to someone who's in severe pain from a physical disability rather than a disease? And is it appropriate for someone with depression?
So the physical disability, if it's not one of the diagnoses we talked about earlier in palliative care, and also if it's pain management without all the other symptoms and needs for other people, they probably best found and treated by a pain management specialist and not a palliative care physician or team. In terms of depression, if somebody has palliative care diagnosis and has depression, yes, they can be treated. Sometimes I've gotten into a situation where I want to get a psychiatrist involved because I want to make sure that it's not the patient's depression that's, the patient's so depressed that they can't make decisions because their depression is overwhelming. But depression as a diagnosis for palliative care, no, but people who are depressed and have other medical problems can be treated with palliative care.
Thank you. I do think we covered the question, does insurance pay for palliative care? We did note earlier that many insurance companies, and including Medicare and Medicaid, do cover palliative care. I think it's something, I don't know if it's 100% all insurance providers, Sharon, but my guess is that you need to check with your insurance provider to confirm. Is that right?
I would think so, yeah.
Yeah. And how does the palliative care doctor interact with the primary care doctor? I think Sharon talked about that a little. I don't know, Sharon, do you want to elaborate a little bit more?
Yeah, we try to keep them in the loop, and kind of, as Carla said, in a way they're like relieved to have somebody else, because usually these patients are needy and call a lot, and the families call a lot. So I think for the most part, they're very happy to have somebody else helping them take care of their patients.
Okay, great. The question was this: how much of palliative care is covered by Medicare? I think that's probably something you need to check with Medicare about. It might differ from patient to patient. Is that right?
I don't know.
With Medicare beneficiaries, if they have Part B, that will cover palliative services. Outside of that, you'd have to check what the plans are with your particular insurance plan.
Cheryl, the one who knows about insurance. Thank you. If one chooses not to go to a doctor to get a diagnosis, can they still have care?
Generally, we do need a doctor's order. Even if someone has not seen a physician in a very long time, we usually need some kind of medical history to know what the past has happened or about diagnoses. A lot of it is a fact-finding mission, and oftentimes when it comes to our program, Cheryl or myself will actually go out and talk to a family and get some history so that we can fill in the gaps and kind of present a case of, is this appropriate or is it not? But legally, to admit on hospice, we do have to have a physician's order. So whether we can find someone in the community willing to see them, whether we can get a nurse practitioner from the organization to go out and do an HMP, history and physical, to determine what's going on, whether we actually look at old medication bottles to determine what diagnoses people have in the past. We usually can make it happen, but it's not something that someone can just call and say, I want hospice. Legally, under Medicare, we have to have a physician sign and agree that they feel like someone's condition warrants the benefit. It's an amazing benefit. It's the highest level of care provided under Medicare, but because of that, there are rules and restrictions, and we have to be meticulous with documentation as well.
Thank you. So someone asked, can you talk a little bit more about how the social worker might interact and facilitate conversations with family members? Like what does that holistic type of care look like?
So when it comes to hospice care, generally, again, I cannot speak of all organizations, but as a social worker myself, we try to get some social history on anyone who comes on our service so that we can build rapport, but also anybody's home that we're entering, we know about them as a person and their history outside of just their diagnosis. Oftentimes people are so much back and forth to the hospital and sick that they're known as the person with dementia or cancer, and not Miss Smith, who is an artist and accomplished all these things. So that's important to build rapport. Oftentimes, again, we're trying to determine what may be causing stress and trying to relieve a little bit of the stress. And for some of our patients, it might be that there's unfinished business, that they're worried about financial affairs, or they want their burial to go a certain way, or there may be estranged relatives that they do or don't want to see. And sometimes there's not those complicated dynamics. For families, a lot of the time is kind of holding the hand to explain what's happening. Caregivers are trying their best to do everything possible to support their loved ones. And we're told the way to make someone feel better is to give them something to eat, help them up, talk to them, these things. And sometimes naturally part of the dying process is that these things don't happen. And a lot of what we do are reassuring the caregivers and families that, hey, you're doing everything just right. But sometimes, again, this is an organic biological process that the body's shutting down. And these are the reasons these things are happening. It has nothing to do with the care you're providing or not providing. It's out of our control. A lot of times it's communication. I see a big part of my role is keeping everyone on the same page. Families do not all live in Atlanta. Sometimes people live in assisted living facilities and the families elsewhere. With coronavirus, families have not been allowed in some of these facilities, and we're the eyes and ears and advocates. So a lot of it is picking up the phone and just questioning and saying, how are you doing? What are your concerns? And again, knowing we cannot take away all of their stress. But if there's practical things, whether it be making lists of things that need to be accomplished, whether it be giving them resources on caregivers so that when people are together, they can spend quality time and again, not be stressed about things that are beyond their control or really don't mean much in the long run.
And our next question, it's a kind of a few questions together. I'm going to list a few different types of other types of care that someone might receive. So things like Can I get physical and occupational therapy? Can I continue to go to the dentist or the eye doctor? Under palliative care, Sharon, are those all things that a patient could do?
Yes, they can.
And how about under hospice care?
Hospice care, we take over everything related to the life-limiting illness and symptoms of that, and that becomes our responsibility. Things that are looked at as completely separate, such as dental care, the ophthalmologist or optometrist, et cetera, those things are looked at as completely separate benefits under Medicare. Podiatry, people can continue to see their regular physicians for that. When it comes to physical therapy and occupational therapy, generally we're focusing on, again, quality of life. And sometimes, sure, doing exercises can be part of someone's quality of life. But to be completely honest and transparent, when it comes to hospice care and the goal is comfort, we can often get an organization to come in and consult for physical therapy and occupational therapy to make recommendations for safety and education and training about equipment. But generally under hospice, it is not restorative rehab. There's not going to be someone there saying, okay, Miss Smith, get on the side of the bed, 10 push-ups or 10 leg lifts, because we're saying take a load off. If you're tired, you don't have to do that. Whereas, restorative rehab is more aggressive. If someone wants restorative rehab or ongoing therapy, I would probably recommend home health care services, which are covered under the Medicare benefit as well. And in conjunction with that, they could often have a palliative care program, and the home health would manage them for, again, therapies. It's a skilled benefit, but it's a very limited benefit. Someone could try to get as strong as possible. You have hospice and, palliative care involved as well to consult for pain, symptom management, and having those ongoing conversations. And then maybe when that benefit, when you've exceeded it or no longer want to participate, transition to hospice.
Okay. Here's a question. You mention often palliative and hospice care being provided in a private residence. What if the patient lives in a nursing facility? This presents different challenges, and how are those handled? Her experience with her having a mother in a nursing facility and on palliative care, it does not seem like the two communicate much. I have not seen much in the way of easing her suffering, which is mostly neurological, not physical, since she has been on palliative care.
Well, different nursing facilities usually deal with one or two hospices, one or two agencies, just because they like having like one nurse come in and be able to see a few people at the same time. I have never worked in a nursing facility. I think you would need to talk to the palliative care people and see what they are doing to help with her symptoms, because even if it's not physical, if it sounds like she has neurological symptoms, I don't know if in the nursing facility, I know some places they have sort of like meetings with all the disciplines getting together. And I think it'd be important to get the palliative care and the nursing facility people together and see what you could work out and what they're saying and what they want to do for.
So I'll ask Carla or Cheryl, and maybe you can talk a little bit about what palliative care looks like with Weinstein, because I know that you do work a lot with patients who live in nursing facilities or in assisted living.
Right. I can speak to the hospice piece of that, in that when someone lives in a facility, like a nursing facility, again, as I mentioned before, we're kind of the quarterbacks. We're coming in and making recommendations and giving people the tools to manage someone's pain or symptoms that are under hospice care. However, the tricky part is we are not in there around the clock. It relies on the staff at the nursing facility to follow through with our orders. So sometimes that is hard because we specialize in symptom management. Not all nursing home staff specializes in symptom management, and they may not feel as comfortable with the medications or not be as skilled on really assessing pain. So things may be ordered at times, but a lot of medications we put in place, it's to say as needed. If you see that Mrs. X is uncomfortable, they can have this medicine. If you feel like she's nauseous or anxious, you can have it. So we're doing our best to educate the staff on what symptoms to look for, but it really does rely on the quality of their staff to follow through with what we're putting in place. But generally with hospice in a nursing home, we send in members of our team just like we would at home. So you have a nurse that's visiting that resident of the nursing home. And instead of looking at the other 20 residents on the floor, they're coming in with laser focus on that particular person to talk about what's working, what's not working. And I know that it's our MO that we are communicating with the staff to say, these are the changes, putting any new orders in place, and then picking up the phone and calling the family. I can't speak to palliative care in a nursing home, maybe Cheryl can, but I will tell you our palliative program is not a home-based program. It's a consultative program. So it may be our nurse practitioner going in 1 or 2 times a month. It's not the same level of oversight and care as hospice. Cheryl, do you have anything to add?
Yeah, no, that's all true. Palliative care in a particular skilled nursing facility can get a little tricky because there's kind of a lot of overlap. There is a medical director in the facility that is still overseeing the patient's medical care. The nursing staff at the facility is and should be communicating needs that from the physician, like if they need adjustments in their medication and, changes in the treatment plan, the facility staff should be coordinating that. And then the representative from the palliative program, in our case, it's a nurse practitioner, and other palliative programs will have their own person and recommendations for changes to that physician so that they're providing that additional set of eyes to be more informative so that the physician, has a more thorough understanding of what's happening and can better treat the patient. And that's easier said than done. So I would, for this person, I would just go back to your palliative care and to your nursing facility director of nursing or whomever to create more of that collaboration because you may need to kind of push that, unfortunately, when they're caring for so many people.
Thanks, Cheryl. Going back to the question about home healthcare, or Carla, you brought up home healthcare earlier when we were talking about like OT and PT. I'm not sure if you know the answer to this, but do you know what the criteria is for receiving home healthcare?
I believe someone has to be considered homebound, or it would be taxing to get out of the house and have a skilled need. So generally it's a Medicare benefit where someone either has skilled nursing needs or skilled therapy needs that a doctor orders home health care, and then a home health agency comes in and assesses, but it's looked at as very short term. So again, Medicare says you have a certain number of visits, a certain number of times a week for a certain amount of time, and then that benefit is completely done. So most physicians are very familiar with ordering home health care, but there's got to be a skilled need. So for nursing, it might be that someone has a Foley catheter. It might be that they need oversight and management of medications, but there's got to be a need. The same with therapy. Therapy can come out, but if they say someone does not have good therapeutic or rehab potential, they cannot provide service. There's got to be some goals, and they have to show progress towards those goals.
Yeah, and the question I see here on the side, needing help with self-care, if that's like grooming and bathing and cleaning up, I mean, there is a word that you've probably heard that people hate to hear, but it's custodial care. And if it's not, and that's what it's called, if it's not medical, if it's just, stuff that you don't need a trained therapist or nurse or anything to do, that generally is not covered by anybody. That's not even a long-term care thing, I wouldn't think.
Right. Someone has to have usually pay for that privately through an agency you're a private caregiver. Unfortunately, it is a big need in a gray area in healthcare. People just need someone to be there as they become more dependent, but also sometimes there's Medicaid waiver programs in the community. There's a program called SOURCE and CCSP if someone meets certain financial criteria and medical criteria. But those programs can be hard to get enrolled in. But unfortunately, under Medicare and insurance, there's just no program that provides kind of just personal care services or ADLs, activities of daily living, regularly.
Great. I know we have just a couple minutes left. I have one more question before we wrap up. What happens if my loved one stabilizes and no longer meets the criteria for hospice care?
That's a great question. And we see it all the time because, again, as we mentioned, we can't predict the future. And sometimes with extra special care and attention, people actually do very well. And maybe just having those people coming into the home multiple times a week is enough not to, again, change the underlying condition, but maybe help things stabilize. If someone no longer meets hospice criteria, we do a discharge process. We do meet as often as needed to discuss certifying someone under the Medicare benefit. For the first 90 days we meet someone, we have to assess, and then after that, every 90 days, and then every 60 days to determine appropriateness. If someone's not appropriate, the social worker and the nurse would absolutely discuss discharge with the family. We don't say, okay, goodbye, see you later. We make it a very smooth transition. We don't tell someone they're being discharged tomorrow. It's usually several weeks or a month in advance this is discussed. We would set up to connect them with their primary care physician, or if they need a new doctor, and make sure they have an appointment or some kind of follow-up with their doctor within a short period of time following hospice discharge. We would make sure that any equipment that needs to be swapped out would be absolutely swapped out. And we would make sure they have a medication supply to last until they get to their doctor. And usually everyone is on the same page. And when someone goes off of hospice, if things change again, they have a right to come back on hospice. This is Medicare benefit. It's something people have paid into, and it's their right to use when the time is right. And even if it's not right now, or it was right and now it's not, and then if 6 months down the road or 2 months down the road, there's not much to lose by
Something showed up under Q&A. Do you see that? I just clicked on that, and it's from Rabbi Cerner.
What if a patient or loved ones are not on the same page regarding palliative or hospice care, if someone is opposed to giving up?
One thing we always try to tell people is we're not giving up. We're changing what we're hoping for. We're changing our goals. I think that sometimes it just takes time. I mean, the patient, if they're able to, should be the one who decides what they want to do, because it's their body and their life. And that's why I see in a couple of months we have this Georgia Directives thing. That's why it's important that people, when they're well and healthy, let their family members know what they want. But I think that sometimes it just takes time, and it's been ugly. And I've seen people where people fly. I had somebody years ago when there were more inpatient hospices, some brother flew in from California and called 911 to the hospice facility and yanked the patient out of hospice and brought her to the ER. So it can be unpleasant. Hopefully it's not. And sometimes with talking and with education and with time, people can get on the same page. But if families had issues before their loved one becomes gravely ill, they will probably have issues, at a time of crisis as well.
Yep. Thanks, Sharon. That is definitely a tricky topic.
Yeah.
And actually something that was talked about in the first session of our education series, our first conversation, which took place at the end of 2021. And so if you want to find the recording to that session and learn more about how to have that conversation, you can go to Jewish Home Life's website, Weinstein Hospice, or Weinstein Hospice's Facebook page to find that link, or send a note to Weinstein Hospice and they can share the link with you. So we are at time. I would really like to thank Sharon, Carla, and Cheryl for joining us tonight and talking about palliative and hospice care. I think this has been really educational for all of us. If you have questions about Weinstein Hospice's programs, both hospice or palliative programs, please feel free to reach out. Cheryl and her team will be happy to work with you. And you can meet great folks like Carla who work with the hospice organization. And as you see here, mark your calendar. We have 2 more conversations coming up in our educational series, one on March 22nd regarding interfaith views on death and dying and hospice. And then as Sharon mentioned, on April 28th, Georgia Directives. What are they and how do they help you? This session is being recorded as well. You will receive a link to it as well as information on the future sessions in the next couple days. So thank you again for joining us, and we hope you all have a great night.